Thank you for this kind invitation, and I hope this lecture we can teach each other and learn from each other. Today we will talk about how to do brain ultrasound and TCD step-by-step approach. I will try to be very simple and we'll talk about basic, and I hope the message will be clear. Our objective will talk about brain ultrasound as a B mode, and we'll talk about brain ultrasound as Doppler. This is a great review in article of Intensive Care Journal, April 2019, talk about brain ultrasonography, methodology, basic and advanced principle, and the clinical application. Very great review. Talk about everything. My lecture, this will be the main reference of my lecture, and to talk about the evidence-based application of critical care ultrasound for assessment of the brain. This is my case report and review articles in the previous year, talking about the brain ultrasound and the TCD, and I will use it in my lecture. First, brain ultrasound as B mode. For the doctors here who are not used to use ultrasound, I need in brief, I talk about the physics. What is the B mode? Use of brain ultrasound as B mode, that means we need to use the brain ultrasound to look for the brain tissue, to see the brain tissue. And very simply basic is the ultrasound probe emit ultrasound beam, and at the same time this intelligent probe will receive the reflected ultrasound from the tissue. This reflected ultrasound, when the ultrasound emitted to the brain, it will face different structure and will get reflection from each structure. And the rule of ultrasound is, if too much ultrasound beam is reflected, if too much ultrasound is reflected back to the transducer, the image will appear white, hyperechoic, like bone, pleura, and pericardium. And if the ultrasound beam, which reflected from the brain tissue, is very low, the picture will appear anechoic, will appear black, like water and blood. And if in between, it will appear gray. So the basic B mode ultrasound, which you see in the screen of the ultrasound, is degrees of gray according to the reflected ultrasound waves from the tissue. As you see here, if too much ultrasound beam is reflected, the image will appear hyperechoic and white. This bone, pleura, pericardium. This is a skull bone. The reflected ultrasound from the skull will be too much because the density of the skull is great, and this will appear as white. And the same with the pericardium here, is very good reflector. Too much ultrasound is reflected from the pericardium, will appear white. But in the contrary, the reflection of ultrasound from the water, like urine in urine bladder and blood in inferior vena cava, will be very little and will appear black. And in between will appear gray, like reflection from the liver, reflection from the spleen and the kidney, they appear gray. And the ultrasound image which appear in the screen is this grades of gray according to the reflected ultrasound beams, according to the density of the reflected tissue. As you see here in this image, you see no reflection from the bile, appear black, And too much reflection from the stone, which is there a lot of calcium, appear very white and echogenic, and in between the liver there is moderate reflection. This is as a B mode. This is what's meant by B mode. We are using the brain ultrasound to look for the brain tissue. How to do it? Very simply, you will use the phase array probe, the echo probe, which will adjust to 2 megahertz. And you will adjust the depth to 13 to 15 and will make the focus at the midline. You will put in the brain ultrasound, we are using the temporal window, which is in front of the ear, above the zygoma. You will see this temporal bone, which is thin bone. We'll use this temporal bone as a window to look for the brain tissue. You see here this open skull from this great image in the stroke article. You will see here the probe in the temporal area, and the ultrasound beam will be directed in this direction, will explore the brain tissue as well as the blood vessels. As you see here, we are using the temporal window, which is present in the temporal lobe. So the ultrasound beam will be directed here in the midbrain and the brain stem. Okay, you know now you will use the phase array probe, and it's not too much windows, only one window, which is the temporal bone above the zygoma in front of the ear. Where do you see your target? What are you going to search? Where is the area you search? Once you put your probe in the temporal window and you will fire the B mode of brain ultrasound, you will see first, there's 3 levels. The first level will be the midbrain. So please, you are here in the left temporal, and you will see this butterfly area of the midbrain with wing looking anteriorly. And as you see, now I'm not looking for the blood vessels, I'm looking for the tissue. You see here, the midbrain appear hypoechoic, and there is white matter appear white, and the gray matter appear gray, and the bone appear hyperechoic. As you see here, this is the CT pictures, but I make it on the side to see. This is the anterior, this is posterior, this is the midbrain, this is the midbrain, this is the temporal window, as you see here. So, number one, once you put the probe in the temporal region, you should see this midbrain. This is your guide in the brain ultrasound entity. Without seeing this midbrain butterfly area with wing anteriorly, you cannot complete your study. After getting this great beauty midbrain, just tilt the probe up, tilting the probe up. That's why, because if you see this brain anatomy, this is the midbrain, and tilting up, you will see the third ventricle with penile body posteriorly. And if you tilt up again, you will see the lateral ventricle. And these are the 3 levels you need to explore. If I tilt the probe up from the midbrain, you will see this third ventricle, which is tubular-like structure with anechoic CSF inside and the hyperechoic wall with a great landmark, which is the calcific penile body posteriorly. Okay, and this is the corresponding CT picture, third ventricle from the temporal window. Just you look for the midbrain, tilt up to get this third ventricle. This is the second level. After that, you tilt up again, you will see this lateral ventricle, and this is the CT image. And if you see, I will see you just tilting. If I get this midbrain, I am tilting third ventricle after lateral ventricle. Just tilting, very simple maneuver. you will put the phase array probe in the temporal window, and after that we are going just to tilt to dissect the brain in these three levels: midbrain, third ventricle, and lateral ventricle. This is the three areas you need to explore as a B-mode ultrasound. What are you searching for? Now you know how to apply what type of probe, how to apply the probe, where to apply the probe, and where is the level, what is the levels you are exploring as brain ultrasound as B-mode. As we just talked about B-mode, we are searching for the brain tissue lesion. What is the normal brain tissue? In B-mode, you are seeing normally in brain, you will see anechoic CSF in the ventricle, and you will see gray hypoechoic of the midbrain and the brain tissue, and hyperechoic bone. This is the three grades of echogenicity you used to see in brain ultrasound. But if you see abnormal echogenicity like that, you see this is abnormal echogenicity. It is less than bone, but probably more than brain tissue. This is hematoma. This is your target. You are searching for abnormal echogenicity other than the CSF and the brain tissue and skull. Number one, using brain ultrasound as B-mode, you are searching for abnormal echogenicity. TCCD, brain ultrasound, can identify and differentiate between intracranial hematomas and ischemic stroke, with hematomas being hyperechogenic, white, and ischemic lesion hypoechogenic. As you see here, this is the third ventricle. We are, while we are talking about the three level of B-mode brain ultrasound, we'll talk about the third ventricle. And as all of you know, the third ventricle, all around the third ventricle, in two sides, there is a thalamus, there is a basal ganglia, there is a temporal loop, and with tilting up, there is a parietal loop. All these areas are the area of hemorrhage. So these are accessible for ultrasound assessment. As you see here, if you see here, you see a frontal hematoma in the right side, and with ultrasound, there is hematoma here, the probe on the left side, and this is the right side. You see hematoma very clear. Here is the hematoma, hyper dense in the third ventricle and in the lateral ventricle, and here. And when I do the brain ultrasound, I see hyperechoic area in front of the midbrain. And here in the left basal ganglia, and here is the right, here is the third ventricle, is the left basal ganglia, hyperechoic lesion, hyperdense lesion. There is correlation between both lesions. And with more experience, you can see cerebral hemorrhage in almost all areas of the brain. Look for this. Look for this. This patient, this is here my probe in the right temporal region. Here is the third ventricle. Here is the middle cerebral artery. You see here, there is hyperechoic lesion here in the left area, just below the bone. And if you see, there is epidural hematoma. And in this patient, you see there is ventricular hemorrhage. And if you see the third ventricle here, there is hematoma moving inside the third ventricle here. Hematoma hyperechoic moving inside the third ventricle, as you see in this clip. And this patient has subarachnoid hemorrhage with hyperdense area, of blood in the quadrigerm cistern all around the midbrain, and with brain ultrasound, as you see here, this is the midbrain hypoechoic, and there is hyperechoic area all around, which is the blood in the quadrigerm cistern. And as you see here, even the posterior cerebral artery, you see here very clear first to second part, and you can swear there is no aneurysm in the posterior cerebral artery here in the left side. Number two, you will look for the ventricular system. You can assess the diameter to diagnose hydrocephalus and interarticular bleed, as you just said, and midline shift. This is the view of the third ventricle in the CT, and this is the third ventricle in the brain ultrasound. It's correlated with the CT, and you can measure the size and diameter here, and it's correlated with CT, and you can diagnose hydrocephalus by measuring the third ventricle. This as a B mode. And as you see here, this is the anterior horn of lateral ventricle, and this is very clear anterior horn of the lateral ventricle. You can measure it very easy, and it's correlated with the CT. So ventricular system is very important for diagnosis of hydrocephalus in a lot of neurocritical care disorder, and they can help a lot. And number three, you need to look for the midline shift. And the midline shift is very important for us in the ICU for a lot of diseases and for follow-up on neurocritical care. As you see here, this is the third ventricle, which is a tubular-like structure with anechoic CSF and hyperechoic wall with the great landmark, which is the calcific penile body posteriorly. And this is the third ventricle here, this is the third ventricle here. And as you see very clearly, third ventricle is the midline structure. And I can use this very important information that the third ventricle is the midline structure, and I can assess the midline shift very easy by measuring the distance from the bone to the third ventricle on the left side, and measure the distance from the bone to the third ventricle on the right side. And by this simple equation, I can measure the midline shift by subtracting the small distance from the long distance and divided by 2, and the midline shift will be towards the short distance. And this is validated in several studies against CT, and it can be used very easy. As you see here, you can assess the midline shift. So, brain ultrasound as B mode. First, B mode is just looking for the brain tissue, the echogenicity of different structure in the brain, and the echogenicity of abnormal lesion like hemorrhage. What is brain ultrasound as B mode? It is looking for the brain by the B mode to assess for abnormal echogenicity, which is the hemorrhage elsewhere in the brain, and looking for the ventricular system if there is any dilatation or increase of diameter as a diagnosis of hydrocephalus, and any intraventricular bleed, and you can assess the midline shift. And there is other several factors, but this is well-known application now for brain ultrasound as a B mode. You are exploring the brain tissue, and as you see, it's only one window, which is a temporal window above the zygoma in front of the ear in this thin temporal bone, and only one maneuver, which is the tilting up. It is a lot simpler than echocardiography. Okay, we now will go to second application of the brain ultrasound as a Doppler. Now we are searching not for a lesion in the brain or the ventricle, but we are looking for the blood flow of the brain. We are looking for the direction of the blood flow and the velocity of the flow in the basal cerebral arteries. How to do it? Very simply, the same way. But here we have several windows. Today we'll talk about two famous windows, through which you can explore all the circle of wheels, which is the temporal and subcortical. First, the temporal window, the same like brain remote, you will put in the temporal bone above the zygoma in front of the ear, phase array probe, which is the echo probe, 2 megahertz. And some machine now, most of the machine now have TCD as a software. You can select it. And the depth is 13 to 15 to see the other part of the skull. And you will adjust the focus in the midline. And as you see here, my probe in the famous temporal window in the left side. And as you see here, the ultrasound beam is directed in this direction. You see very easy, you can explore the middle cerebral artery, which is moving towards the ultrasound beam, and the anterior cerebral artery. And if you tilt downward, only just a little downward tilt, you can explore the two posterior cerebral artery, and you can complete the circle of wheels here. But now we are not using the rule of B mode, which is depend on the reflected ultrasound, and according to the reflected ultrasound will be the echogenicity in the screen, and this reflected ultrasound depend on the density of reflected tissue and lesion. Now we are using another rule, which is the Doppler rule, and we need to know about Doppler equation, because through this equation, this intelligent machine can measure the velocity. But I am sure you are doctor, you are all doctor because you hate this type of formula. But very simply, I will not discuss in details, but the aim of ultrasound, brain ultrasound as a Doppler mode is to measure the velocity and direction of the flow. Velocity and direction of the flow. Velocity by Doppler equation, as you see in this formula, this C, which is the velocity of the ultrasound in the blood, which is that fixed number, 1,540 meter per second. And this F, which is the frequency of the probe, which is also the fixed number, 2 megahertz, and frequency shift, but it's also depend on the flow of the red blood cell. So you have three factors here. You can do nothing for these three factors. It is don't rely on you as a sonographer, but the last factor here, which is the cosine of the angle of insonation, this is rely on you, and this you should do it in proper way. You need to adjust the angle of the probe to get in parallel to the blood flow as much as you can. And as you will see now by the brain ultrasound, the TCCD, you can see the blood vessels and you can put the pulsed wave in the direction almost parallel to the blood flow. It's easy business for the TCCD, not for TCD, which is old machine. But you need, if you don't remember this formula, which is the Doppler equation to measure the velocity of blood flow, you need to know the imaging rule of Doppler, which say any blood flow towards my probe here in the temporal area will appear in red, and in spectral Doppler will appear above the baseline. As you see here, this is systolic velocity and this is the diastolic velocity. And any blood flow away from my probe here will appear in blue, and the spectral Doppler will appear below the baseline. This is the imaging rule, and you need to know that as a sonographer. And as I said to you, please don't proceed in brain ultrasound without seeing this beauty butterfly, which is the midbrain. Don't proceed in brain ultrasound B mode or Doppler without seeing this midbrain through this temporal window. Because as you see here, the midbrain, you will see all the circle of wheels all around in front of the midbrain. As you see here, the posterior cerebral artery circulating around the midbrain, in front middle cerebral artery going in this direction, anterior cerebral artery going in this direction. So it's very important to localize midbrain before you proceeding to complete your examination. And fortunately, as you see here, this is the skull base, and we are assessing the basal cerebral arteries. And as you see here, fortunately, this is the midbrain, and in front of the midbrain, here is the cavernous sinus, and this is the internal carotid coming from the cavernous sinus, will give the middle cerebral artery and the anterior cerebral artery, and here the basal artery will give two posterior cerebral artery. This is the circle of Wills, and as you see here, all are accessible. Most of the circle of Wills are accessible from the temporal window here. You can see this middle cerebral artery and this anterior cerebral artery and this posterior cerebral artery very clearly. You compare this CT angio with this great brain ultrasound as a Doppler. You can see here is my probe in the right temporal area, and I explore the midbrain here, which is the butterfly area with wing looking anteriorly, and you see the posterior cerebral artery on the right side curving around the midbrain, and the middle cerebral artery going towards my probe, so appear in red, and anterior cerebral artery in the right side going away from the probe, appear in blue. But the anterior cerebral artery of the right side, of the left side here, because here I'm right side, here left side, going towards my probe to meet the other anterior cerebral artery, so appear in red. So this is the circle of Wills, and this is the circle of Wills. And as you see, the clue here is the midbrain. Once you get the midbrain, everything is very clear. You see here, this is the internal carotid artery giving anterior and posterior and the middle cerebral artery. Here is the middle cerebral artery giving anterior and middle cerebral artery. Here is middle cerebral artery, anterior cerebral artery. But to explore the vertebral artery and the basal artery will be very difficult to get it from here, but very easy to get it from here, subcostal. This is a CT angio, but I make it upside down. This is a suboccipital window, and I put the probe here. As you see, you will see this two vertebral artery and the basilar artery, V-shaped, inverted V-shaped, and the basal artery very clear appear in the here subcostal view. This is the vertebral artery upside down and giving to basal artery in this V shape. And as you see, it's only one window, one probe, one frequency, and one maneuver, which is the tilting. You can know a lot. You can diagnose very important disease and lesion in the intensive care. And moreover, we can use this brain ultrasound to assess the conscious level in patient before weaning and a lot of other indication. But I need to be very simple in these lectures, and I need to talk about very apparent areas. And thank you a lot for your appreciated listening, and I would be happy to explore any point anyone needs to. So thank you a lot. Thank you, Dr. Walid.
Thanks very much, Dr. Walid Shibl. Kindly put your questions in Q&A sections. So I'm stopping your presentation now, Dr. Walid, and we'll put the poll for documentation of attendance as usual. So you can start voting now. So Dr. Walid, if you give us like a quick idea about, until we get some questions here in the section, if you give us a quick idea of how beneficial the ultrasound could be in subarachnoid hemorrhage in a patient that is possibly developing a cerebral vasospasm instead of going to CT brain every 12 hours and sometimes more frequent. That's one of the common patients we see in our practice in critical care, surgical intensive care. or trauma ICU, a lot of patients coming with cerebral hemorrhage, either medical or surgical bleeds. So is there any difference between both of them in the term of cerebral vasospasm, and what's the role of ultrasound, if any? Thank you.
Great, Dr. Walid, great questions. And this will reveal very important point. And we face it a lot because subarachnoid hemorrhage is not only with medical people with rupture aneurysm. It is very common with traumatic brain injury. You can
Yes.
see reaching almost to 50%, 40 to 50% of the people has this vasospasm. And as you just mentioned, Dr. Walid, very clearly, you cannot send your patient to CT every day to check for vasospasm and to check for the complicated hydrocephalus. And it's very annoying for the patient, and a lot of radiation. And how can you our patient in ICU, this trauma, brain trauma patient and neurocritical care, low stroke, this probably are sedated. Well sedated يعني. We don't have even proper clinical assessment for the patient. But if you put the phasor ray probe in the temporal area and measure the velocity and document this velocity, and this is already evidence-based, she score evidence 2A. Score 2A in American Stroke Association and the American Heart Association. In the last guideline, the assessment of the vasospasm by TCCD, and now we are not talking, there's very little difference, very important to know. There is TCD and TCCD. What we are talking now is the brain ultrasound, is TCCD. We see the blood vessels, as you just saw. We see and we can put the pulsed wave. But the TCD, which is a blind technique, it's all technique, and we are not talking about that. This indication, one of the most important indication, and can help a lot. And there's other indication, Dr. Walid. I faced several patients in the last period. It's very important to check the conscious level before extubation and weaning. Is it right, Dr. Walid?
Yes, correct.
And your patient on sedation, and you may be misinterpreting the conscious level. But if you put the brain ultrasound and you saw too much velocity, you can send your patient to CT before going to extubate. And I faced 2 patients like that, especially in the era of the COVID. And there's abnormal brain Doppler, very abnormal, very distressing. I send the patient to the CT, and there is severe brain edema. This is a lot of indication, really. But as you saw, it's now evidence-based, and the evidence is coming. This review I mentioned in the Intensive Care Journal, April 2019, believe me, the time after this review, it's not before this review. In these reviews, they are talking now about certification. There is basic certification and the advanced certification. It's really different. But
it's growing very quickly.
It's
growing very, very quickly. So here you mentioned these 2 patients that had very high velocity. So I think, correct me if I'm wrong here, if you detect very high velocity on the middle cerebral artery or one of the cerebral arteries, do you do the Length-Guard ratio and go to the carotid first?
Excellent.
Or do you have a look on the blood pressure to see? Because I believe if the patient is have some pain and his blood pressure is 180, and he was normal velocity on the middle cerebral artery before, now it will be high. So what do you compare with? Is it the arterial line tracing, or is it the Length-Guard ratio on the carotid? What is your baseline?
Very simply, if there is stenosis or spasm local in the middle cerebral artery or anterior cerebral artery, that means the velocity will increase in this artery. But as you mentioned, if the patient has hyperdynamic circulation, if the patient under triple H therapy with hemodilution, hypervolemia, and hypertension, this patient will have high velocity all over. As you mentioned, now we used to do Length-Guard equation. If I saw too much velocity in the mid-cerebral artery, I will assess the velocity in the feeding artery, which is the internal carotid. If it is generalized process like hyperdynamic circulation it will increase in both. But if the velocity in the midcerebral artery more than the internal carotid artery by 3 factors, it is spasm, it's mild spasm. If it's more than internal carotid artery by 6 fold, that means severe spasm. And also assessing the carotid is not, carotid is very superficial, and you can assess by a linear probe. And this, believe me, this maneuver is too much easier than the echo. I know you are expert in echo, Dr. Walid, and you can mention how many window for the echo, how many tilting and rotation and leaning, how many. Like we are talking about one window, one tilt. Yeah, it's very simple maneuver, but you should try it. And already the echo is the echo probe, and it's not.
Surprisingly, Dr. Walid, I was attending one of the webinars, virtual webinars from Canada yesterday with a new Canadian team in neonatal echocardiography, and they are using the phased array and the linear probe as well to diagnose a lot of transcranial pathologies, because you know the fontanelle is open, so their window with ultrasound is almost as sensitive as the MRI brain. So they did a lot.
Believe me or not,
it's
the
teaching and
standard
training.
in neonate, the standard is the brain ultrasound. They compare the MRI by brain ultrasound because this is the standard. Believe me or not.
Yeah. So I think it's coming in the horizon very quickly. This is all new modalities. There is a lot of workshops now happening in neonates, in pediatrics, in infants, and even intrauterine. So I have a question here. Transcranial Doppler have any role in sickle cell disease and fat embolization? If I got the question right from Raghib al-Misiri. So he's asking about SCD. I believe this is sickle cell disease and fat embolization. Do we have any rule from ultrasound on the brain?
It's very nice questions. طبعا sickle cell disease, it is a very strong recommendation to follow the sickle cell disease by brain ultrasound, because if you find too much velocity in the midcerebral artery, this is indication for blood exchange, and you need to keep always the hemoglobin S below 30%. And this is hard fact. It's grade 1 evidence. In sickle cell disease, it is a must. You should do transcranial Doppler. In fat embolization, the TCD is the only imaging which can reveal the microemboli. No other imaging modality can assess and can look for the microemboli. And the fat embolization is a sort of this microemboli and appear very clear as high intensity signal, because imagine in this for a second. Brain is 2% of the body weight and receive 20% of the stroke volume. The best flow ever in the brain is the brain circulation, is the middle cerebral artery, mainly middle cerebral artery. The flow in the middle cerebral artery is the best flow ever in the body. So you can see through this very clear flow and very huge flow, you can see microemboli. Very easy. And if you see it once, you will not forget. And there is 5 case report about diagnosis of fat embolization of the femur fracture by looking for the TCD. Very nice questions, really. Very nice.
Perfect. So is it a tool to diagnose brain lesions or just for follow-up? He means the diagnosed lesion according to guidelines. A question by Muhammad Al-Aidi.
There is evidence-based you can diagnose brain hemorrhage. As you saw, I saw in 6 cases of 7 cases of brain hemorrhage, you will see hyperechoic lesion. There is a study done on 151 patients. There is very good correlation between the brain ultrasound and the CT. Almost sensitivity is 95, specificity is 95 to diagnose brain hemorrhage by brain ultrasound. But you should have, the only obstacle is the window, because temporal window may be an obstacle in 12% of patients. So you should have a window to be sure you are exploring the brain tissue and you are diagnosed brain hemorrhage. As regard brain hemorrhage, it's evidence-based 2B, evidence-based 2B to diagnose brain hemorrhage, and you can diagnose midline shift by this simple equation, and this is validated against CT. But if the lesion, brain tumor, I don't hear about brain tumor. We are talking about hemorrhage and follow-up hemorrhage and midline shift and hydrocephalus. I am talking about 3 points. This is the most important, and there is a study about that. But the problem, no new studies. These studies all were old, and despite the good sensitivity and specificity, something surprising, they are not doing a large one. We need, with Dr. Walid, inshallah, will try to do it in Mahad, inshallah. We should do a big one about that, multi-center.
So that takes us to the next question. Yeah, that takes us to the next question about how to measure the ICP by ultrasound. I'm sure he's talking about optic nerve, not Doppler or anything else. So what's your input in that regards by Dr. Negm and Dr. Muhammad Muqbil? Both are talking about ICP measurement.
Okay, ICP measurement, okay. The people who talk about ICP measurement, really, there is 2 groups here. I think Bellner and Zwiffel, and there's some people talk about, they were very eager. We can do it. We can measure ICP through the brain ultrasound. And the theory here was if the increased intracranial pressure will press on the venous system and small arteries, this will impede the blood flow in diastole compared to systole. So what's called the pulsatility index will increase. And they mentioned BI is very sensitive to diagnose increased cranial pressure. But unfortunately, the coming study after that, they disregard this issue about the role of the BI in the diagnosis of increased cranial pressure. طبعا they are talking about the non-invasive against the gold standard, which is the invasive. So there is still controversial point, but it's very important point. Why there is misleading point? Why PI? Some people say the PI is very important to diagnose increased cranial pressure, and some people say it's not. This is because there is other factor increasing the PI, like heart rate, like pulse pressure, like very important peripheral vascular resistance, like blood pressure. And they mention 4 to 5 factors can affect the PI. So in this great article, if you read it with all subdivision, this article in the Intensive Care Journal, April 2019, he mentioned very important. You may rely on the BI in the assessment, because BI is very easy to measure. You may rely on BI in diagnosing increased cranial pressure if you have pulse pressure less than 60 and mean pressure normal and heart rate is not bradycardic. With this precaution, and with CO2 is normal. If you have this 4 parameters and you can get this parameter in ICU, you can rely on BI. This is number 1. Number 2, Professor Roba, genius professor, really had a lot of articles and publication for brain ultrasound. It's genius. She started to talk about why we are using only 1 parameter like optic nerve sheath diameter in diagnosis increased cranial pressure. She used another parameter. She used the PI with optic nerve sheath diameter, and at the same time, she used the big velocity of the venous sinuses, the straight sinuses. And she found the area under the curve, which is due to sensitivity and specificity, was more when using more than 1 parameter. And this is what I'm talking about. We are talking about brain ultrasound TCT. You are put the phase array probe, measure the PI, measure the optic nerve sheath diameter, look for the midline shift, look for the hemorrhage. This is 4 factor, and use this 4 factor will increase your sensitivity. I'm sure if you do score like Marshall score with these 4 factors, I'm sure if you compare the increased sacral pressure with the gold standard, which is invasive, I am sure you will find a very good sensitivity and specificity. This is as regard. I'm sure the people who ask about that, they know about the controversy, but now I hope I clarify the point.
Okay, just for our colleagues that may be not familiar with what is PI and RI. The PI is pulsatility index and RI is resistivity index, and this is part of any vascular Doppler examination. When you map all the tracing, so you get the pulsatility and resistivity index. You use pulsatility index in certain occasions and resistivity index in another occasions, but this is tools like the cardiac output assessment in hemodynamics, something like that, if it is the same similarity. So if any of our consultant speakers, attendees has any questions, please let me know, or you can straightforward open your mic and ask your question. Until that happens, we have a couple of questions asking about ischemic stroke, Dr. Walid. Is there any role of ultrasound to diagnose ischemic stroke, particularly if the window time has passed and we don't have a facility for a CT, plus minus follow up before and after RTPA? Is there any role for ultrasound?
Yes. This is validated. There is a rule for that. As you see in this lecture, the flow in the midcerebral artery and the anterocerebral artery, sensitivity of seeing the obstructed flow in the midcerebral artery due to embolus or thrombosis is high. Compared to CT angio, it's almost 90% in midcerebral artery. And it's very high sensitivity in the diagnosis of stroke. And moreover, you can follow for recanalization. You will not send your patient to CT angio several times per day, but you can assess the recanalization every couple of hours. You can do it. And as early, if there is early recanalization, this is good prognosis. And you can talk with the relative about the prognosis if you got this early recanalization. And moreover, the complication of stroke, you're afraid from the midline shift with the malignant midcerebral artery. You will follow the midline shift every day, okay? And hemorrhagic transformation. Good. If you give, you can very easily detect hemorrhagic transformation in the. It is easy, but you need to do it. You need to start to do it because. Yes.
A question from Dr. Negm again. If you detect the velocity in the internal carotid artery and the velocity in ICV, I don't know, is it cerebral vein or something, can you detect blood flow in brain to consider the ICP? I don't know if I got his question right.
What is done here? Very important formula. The formula validated against the gold standard, which is invasive. This formula said simply, cerebral perfusion pressure equal mean arterial pressure multiplied by diastolic flow velocity over mean flow velocity plus 14. There is a study done for that, and this formula was validated against the gold standard. But they rely on TCD because they did a lot of TCD. You will connect the machine and she can be monitoring for 30 minutes, 1 hour, and it is continuous monitoring, spectral monitoring. And with this machine, but I used to do it in ICU because for this patient, which has increased sacral pressure, I can do it frequently by TCCD, and it's very easy, as Dr. Walid said. The machine, you will put the pulsed wave Doppler in the midcerebral artery. The machine will measure all this for you. the machine will measure the mean velocity, diastolic velocity, everything the machine will do. And if you have arterial line, you have the mean arterial pressure. And you can do this formula, because if you measure the cerebral perfusion pressure, very easy with mean arterial pressure, the difference will be intracranial pressure. This formula is validated. This formula is validated. But if you measure the venous and arterial, it's long pass. This is the recommended formula. This is the recommended formula.
Perfect. One of the interesting publications a few years ago as well in anesthetics, Dr. Walid, you asked me about the implications in anesthesia. You know, cerebral circulation is of one of most interesting concerns intraoperatively, particularly with hypotensive anesthesia. What is the lower limit possible for the blood pressure and the cerebral perfusion pressure? So one of the nice publications, it was a few years back, I read it maybe 3 or 4 years back. So they put the Doppler of the echo probe here, and they fixed that with a bandage. And they kept monitoring the cerebral blood flow with different blood pressures, and they see when is like cerebral blood flow, and like, you know, they measure the pulsatility index and diastolic flow, and they see below 30 or 40, and they measure the mean pressure, and they see like, and they found that they did a lot of patients without intervention with the hemodynamics, because diastolic flow was satisfactory even with a lower mean arterial blood pressure. I think the only thing against this publication, which made me a bit difficult to believe it, is how to, like, if the surgery is 3-4 hours, how you keep this probe position fixed in the window with the gel in place, with everything right
in this,
2-3 hours.
In this situation, he will use not the TCCD, he will use the TCD, because there is helmet, they can fix the TCD.
No, this is not what was mentioned in the article. It was the phased
TCCD,
array probe of
very
an
strange, very strange.
Yes,
very
yeah,
strange.
yeah. Believe me, I'll send you this article if I find it again. But I'll send it to you. It's a very interesting one.
Yeah.
So thanks very much, Dr. Walid. I think we have no more questions here, and like, we do really appreciate your presence with us tonight and your effort. And it's good to know and to publish that Dr. Walid Shibl is teaching a brain ultrasound course coming soon under Saving Lives Academy, and will put all details on the website soon, inshallah. So for whoever is interested, there is a lot of potential publications for the masters and MDs, and a lot of, it's a very good area for new research. If you're looking for a genuine and legitimate research questions, there is a lot of open areas for research in the moment and for the last few years about transcranial ultrasound implications in anesthesia and critical care. So thanks very much, Dr. Walid, again and again, and see you again soon, inshallah.